Your LDL can look perfect, and your arteries can still be grumpy. The missing piece is ApoB. If LDL-C is the amount of cholesterol, ApoB is the head count of the trucks hauling that cholesterol around. Arteries do not like traffic jams. More trucks means more dings on the artery wall, even if each truck carries only a small load. Here is the simple version. LDL-C tells you how much cargo is in the system. ApoB tells you how many cargo trucks are on the road. Every risky particle has exactly one ApoB tag on it. Count the tags, and you know how many trucks are out there. When it comes to plaque, the truck count matters more than the total cargo. Let me give you a friendly example. Two neighbors both have an LDL-C of 95 milligrams per deciliter. One has an ApoB of 75. The other has an ApoB of 110. Same cargo, different number of trucks. Who creates more traffic on the artery highway? The one with ApoB of 110. That person has more particles bumping into the artery wall all day long. Why would trucks multiply when the cargo looks average? This happens with insulin resistance, extra belly fat, high triglycerides, or fatty liver. The body makes lots of small particles that each carry less cholesterol, which keeps LDL-C looking okay, while the count of particles shoots up. That mismatch is called discordance. When LDL-C and ApoB disagree, follow ApoB because it is the direct head count of troublemakers. You do not need a PhD to use the numbers. ApoB of 130 milligrams per deciliter or higher is a red flag in U.S. prevention guidelines. Many clinics aim for ApoB under 80 if you are high risk and under 65 if you are very high risk. There is also LPOA, which is like a sneaky VIP riding on an ApoB particle with its own risk. Most Americans only need to check LPOA once in their life, unless a clinician says otherwise. If your LPA is high, it adds risk on top of ApoB, so you will want a tighter plan. When should you ask for an ApoB test in the United States? Ask if your 10-year heart risk is borderline or intermediate and you need a tiebreaker. Ask if you have metabolic syndrome, type 2 diabetes, high triglycerides, obesity, or fatty liver. Ask if you have a family history of early heart disease. Ask if you already take cholesterol medicine and want a clearer target than LDL-C alone. In short, if you are trying to get serious about prevention, ApoB is your scoreboard. Ordering the test is simple. Tell your primary care provider, which Americans call a PCP, that you want ApoB added to your lipid panel. It is a standard test at national labs like Quest and LabCorp. Insurance coverage varies by plan, and Medicare sometimes asks for a form called an advance beneficiary notice. If your clinic asks why you want it, say you are checking particle number to better match treatment to risk. Fasting is not required for ApoB by itself, but if your clinic pairs it with a full fasting panel, follow their instructions. Bring your patients and your copay, and you are set. Now let's talk about what to do with the number once you have it. First, look at ApoB directly instead of guessing from LDL-C. If you are high risk, under 80 is a common goal. If you are very high risk, under 65 is often used. If you see 130 or higher, that is a strong nudge to act. Second, check for discordance. If LDL-C looks fine but ApoB is high, trust the particle count and adjust your plan. Third, make sure you have checked LPOA at least once, because it can explain why risk stays high when everything else looks tidy. Lowering ApoB starts with your daily routine, not a magic supplement. Think of your liver as the shipping department. If you send fewer orders, fewer trucks hit the road. Losing 5 to 10% of your body weight can cut the number of trucks your liver releases. Swap butter and heavy cream for olive oil, nuts, seeds, and fish, because unsaturated fat helps the body clear particles more efficiently. Add soluble fiber from oats, beans, and psyllium, which acts like a sponge for cholesterol in the gut. If your triglycerides are high, dial back sugary drinks, desserts, and alcohol because they pump out extra remnant particles. Move your body most days with a mix of brisk walking or cycling and some strength training. Think of exercise as highway maintenance for your blood. Medications can lower ApoB further when your risk is high or lifestyle changes are not enough. Statins are the standard first step, and they lower both LDL-C and ApoB. Ezetimibe blocks cholesterol absorption and is a simple add-on. PCSK9 inhibitors like alirocumab and evolocumab and the shot called inclisiran can drop ApoB and a lot for people at very high risk or who cannot tolerate statins. Bempedoic acid is an oral option when statins are not a fit or when you need extra lowering. Your clinician can help you pick the right mix based on your risk, preferences, and insurance. Here's a quick, no-drama script you can say in the exam room or through your patient portal. Could we add ApoB to my lipid panel? I have risk factors, and I want my particle number to guide decisions, not just LDL-C. I would also like a once-in-a-lifetime LPAA test. If ApoB is high, I'm open to lifestyle changes and medication. A few myths deserve a friendly takedown. Myth 1 says ApoB is only for cholesterol nerds. Reality says it is in major guidelines and used every day in lipid clinics. Myth 2 says a low LDL-C means you are automatically fine. Reality says discordance exists and a high truck count can hide under a normal cargo number. Myth 3 says you must fast for ApoB. Reality says ApoB does not require fasting, though your clinic may ask for fasting when bundling other labs. Let's land this plane. LDL-C is cargo, ApoB is the number of trucks. Arteries care about traffic more than cargo. If LDL-C and ApoB disagree, follow the particle count. Use ApoB and a one-time LPOA to personalize your goals, then recheck after big changes to make sure your plan is working. Your future heart will thank you, and your arteries will enjoy the quieter commute.